Good morning, everyone. My name is Ifeanyi Onubogu, and my study was on a review of whether we can use distal femoral arthroplasty as a primary treatment option in the treatment of such fractures in the elderly. So these fractures are defined as traumatic events which occur within the region extending from the distal metaphyseal diaphyseal junction of the femur to the articular surface of the knee. They account for between 3 to 6% of all femoral fractures and have an initial bimodal distribution with an initial peak with young adult males due to high energy trauma, or second peak with elderly females who tend to be osteoporotic. And the average age of the second peak tends to be around 82 years of age. A classification can be descriptive based on the location of the fracture, whether it's supracondylar or intracondylar, or it can be with the well-known AO classification, which is subclassified into 3 categories, with A being an extra-articular fracture, B being partially articular, where part of the articular surface is in continuity with the shaft, and C, where there is a complete intra-articular fracture, where there's no continuity with the shaft at all. So the best practice tariff that was initially introduced in April 2010 for hip fractures in the United Kingdom to provide optimal care for patients admitted with neck and femur fractures. The aims were to encourage prompt surgery and the appropriate involvement of geriatricians to improve patient outcomes and reduce mortality in patient populations with significant comorbidities. The successful implementation of this for hip fractures reduced the average 30-day mortality from 7.1% to 6.1% between 2016 and 2019. The NHS England extended the scope of the best practice tariff to include all fractures of the femur, so including distal femoral fractures, in April 2020, to ensure that patients who tended to have a similar comorbidity profile were given the same holistic care as those with proximal femur fractures. And they were encouraged to do this with monetary incentives to achieve all of these 6 markers for each patient presented with a fracture. So current management includes non-operative in the way of above knee plaster casts or braces and splints. And these are for fractures that are minimally displaced or stable in their configuration. This negates the risk of associated with surgery. However, it would require prolonged joint immobilization and high levels of patient compliance to achieve a good outcome. And considering our second peak of the bimodal distribution, it may not always be possible in this patient cohort. Surgical options include locked plating and intramedullary nailing, and they're the current standards of care. They offer stable fixation in good quality bone, providing good resistance to inherited deforming forces. The locked plates tend to be used and indicated with comminuted intra-articular fractures deemed amenable for fixation, with specific consideration given to sufficient bone stock for permitting predictable fracture fixation. Intramedullary nailing can provide a good fracture stability with a minimally invasive approach. This technique has been used predominantly in extra-articular fractures. However, advancements in technology over the past few years have allowed newer implants, which include multiple distal screw options, which allow articular reconstruction in simple intra-articular fractures. Complications with this technique can include loss of distal fixation, leading to penetration of the knee joint on actual loading. Distal femoral replacement offers arthroplasty as an alternative option, which allows early mobilization postoperatively and reduces the risk of complications associated with fixation, such as non-union. Indications of this are similar to fixation, but highlight significant comminution at the fracture site, preoperative pain or concomitant joint arthritis, or inadequate bone stock with osteoporosis. Although there's limited evidence at present, it may be of benefit as a treatment option for a select group of patients. We have a number of prostheses that have been used in the literature for distal femoral replacement, including Stryker's GMRS, Zimmer's, Zimmer Biomet's OSS, and Implant Cast DFR. There's no evidence to prove superiority amongst any of them. However, in the literature, Zimmer Biomet's OSS has been preferred by some surgeons due to its minimum required bone section depth of between 3 to 5 centimeters. This is lower than other implants, such as implant cast, which requires at least 7 centimeters of bone resection from the knee joint. And these tend to be tumor prosthesis that have been used in the fracture setting. The link endo model, which is a rotational hinge knee, doesn't require full resection of condylar bone and is predominantly used in primary and revision arthroplasty surgery. There's limited evidence and research into its use in the trauma setting. On that note, these implants can be either cemented or uncemented. However, because of the nature of the injuries and more commonly seen in osteoporotic bone, they tend to be cemented in situ. So the objective of our study was to review the use of distal femoral replacement as a primary treatment modality, and we compared distal femoral replacement against plate fixation. We did a comprehensive literature research using Medline and Embase databases, using the keywords distal femoral fracture, replacement, fixation, repair, and elderly. And the abstracts were reviewed to identify relevant articles, and the following factors were analysed, including time to surgery and post-op mobility status. This is a summary of the results that we had. So we had 5 articles which compared directly DFR and fixation. The highest level of evidence provided in the majority of articles were analysed for level 4 evidence, such as case control studies or cohort studies. The study produced a sample of 200 patients treated with distal femoral replacement and found that 87% were ambulatory at 1 year follow-up, compared to 78% in those treated with reduction and fixation. Study by Appleton had the largest sample size of 54, with a mean age of 82 years, with 94% of the patients being female, corresponding with literature on the patient demographics. The remaining studies included fewer patients treated with DFR, ranging from 12 to 54. In patients treated with the DFR, complications included superficial and deep wound infections and a periprosthetic fracture following further trauma, of which there were 4 such complications within 3 months of surgery. With regards to getting patients to theatre, with it being a specialist procedure and a knee specialist or trauma surgeon with appropriate experience will be needed to perform the operation, which can be a limiting factor in providing adequate treatment. Paper by Betting et al. Found that the average time to finish the surgery was 7 days, while actually found they averaged just under 6 days. In a study comparing the use of DFR and plate fixation in periprosthetic fractures, the time to surgery differed, with being averaging 2 days for distal femoral replacement and just over 1 day for ORIF. Was one of the primary aims of the best practice tariff now encouraged to bring in prompt surgery. This presents a limitation of the use of distal femoral replacement as a primary surgical option. The procedure, however, does allow immediate postoperative weight bearing compared to plate fixation, where it's normally restricted to allow time for union. The literature found that surgeons are tending to move towards early mobilization in their postoperative management, with either allowing protected weight bearing with lock plating or making use of intramedullary nailing, which is a load showing device. We found that patients who were treated with a distal femoral replacement were weight bearing in under 2 days. However, there was an average of 11 weeks to full weight bearing for those treated with fixation. The average hospital stay found by a study by Hart was 7.5 days in those treated with an ORIF, and it's very similar to those treated with a distal femoral replacement, which was 7.3 days. Those who are non-weight bearing following an ORIF are also affected by the social issues of discharge due to the availability of places at rehabilitation centres, which is quite a big problem in the UK at present. Postoperative mobility status was found. Majority of patients we treated with a distal femoral replacement were all ambulatory at 1 year. However, a big proportion of that were requiring the use of a single walking aid as a minimum. However, in the ORIF group, 23% of patients were wheelchair bound at a year. However, 27% of those of the remaining patients were fully independent without the need for any walking aids. With regards to complications, one study found no significant difference in the two groups with postoperative complications. However, another found that 1 in 5 patients of the fixation cohort developed a non-union, which is consistent with literature regarding non-union rates. Another study found there was no complications in the DFR cohort compared to 1 failure fixation, 6 non-unions, and 2 infections in the fixation cohort. The risk of further surgery on average was similar between the two, 13.3 versus 13.5%. However, the risk of complications lower with distal femoral replacement. This treatment option may offer a valuable singular treatment modality for those patients who either may find compliance with non-weight bearing difficult or have a significant mobility profile. One of the other things we looked at was the cost. The cost of a distal femoral replacement is greater than that of plate and screws used for fixation. However, when you take into account time to hospital discharge, patient being fully weight bearing, and possible community support, the overall cost of the procedure end up being similar, with an approximate cost of £10,000 for distal femoral replacement and just under that for fixation. Despite the slightly higher cost, the favorable outcomes with regard to weight bearing and postal ambulatory status highlight an overall greater cost benefit when compared to fixation. As to conclusions, distal femoral fractures can be quite difficult to treat due to poor bone quality in osteoporotic bone and likely pre-existing arthritis. Intra-articular complexity also makes these quite difficult to treat. Distal femoral replacement offers a surgical option that allows patients to immediately mobilize post-op, which reduces the risks of associated with non-weight bearing, such as pressure sores and risk of venous thromboembolism. With the extended best practice tariff to include all femoral fractures in the elderly, early mobilization is a key step in reducing mobility and mortality. Hence, a distal femoral replacement should be widely considered to help achieve this. As to limitations of the study, as a less prevalent injury, there's a lack of evidence directly comparing the two modalities. So it's given us a small sample size. The heterogeneity of the studies also makes the comparison of results through meta-analysis difficult. The focus of the paper also only compared distal femoral replacement against plate fixation, And with, as I mentioned before, the new technologies are allowing surgeons to encourage earlier weight bearing, but also use nail and plate combinations to aid fixation. Going forward, we prefer research to provide high-level evidence than currently available to investigate relative short-term mortality and long-term outcomes with regards to prosthesis. This will all contribute to the overall cost-benefit profile of the procedure, with a well-designed prospective randomized control trial comparing two treatment modalities, and the new fixation options, as mentioned, could help to establish best practice for these injuries. So these are the references. So thank you very much. I'll stay on to any